Welcome one and all for the webinar from ASSET, that is Amity School of Engineering and Technology, Amity University, Haryana. As you are aware, Amity University, Haryana is known as Research and Innovation Driven University. The birthday of Honorable Chancellor Dr. Asim Chauhan on 28th September is celebrated in the campus as Innovation Day. And every year, 1 week prior to the celebration of Innovation Day, many activities of research and innovation were conducted and displayed. This year also, amidst the pandemic of COVID-19, AUH is organizing webinars from renowned resource persons and carrying out the research and innovation activities. The present webinar is one of this series being conducted by ASSET. We thank Honorable Chancellor, Vice Chancellor and Pro-Vice Chancellor for their motivation, support and guidance for carrying out these activities. I wholeheartedly welcome the today's speaker for the event. I request Sanjeev Jogi sir to speak, introduce the speaker before we start the session. Thank you.
Thank you, sir. Good morning, one and all. Thanks for joining the today's session of MIT Innovation Week. Today, Department of Biomedical, on the behalf of MIT Universities, is pleased to welcome Dr. Anirban Gupta, a very special guest from Vanderbilt University, USA. Dr. Gupta have very special interest in the field of biomedical as he done BTech, MTech, PhD in biomedical engineering. He have done his education from the IITs and IIT Delhi. And he worked on multifaceted problems and approach to fill the gap of healthcare needs and engineering solution. Today, we get the opportunity to listen his experience on MRI, neuro disorder, and image analysis technique. With the permission of Director ASSET, I cordially invite Dr. Gupta to share his experience on topic MRI in neuro disorder diagnosis and its connection with everyday life. Dr. Gupta, please.
Yeah, thank you, everyone. First of all, a very good morning to everyone in India. I'm really privileged to be invited as a speaker in Amity University. Amity University is one of the most esteemed universities in India, and I have got the privilege of acting as one of the members in devising the syllabus recently, curriculum for biomedical engineering in Amity University. So being a part of biomedical fraternity, I can vouch for the high standards that Amity University maintains in a lot of different disciplines under its umbrella. I particularly was impressed by the fact that they put a lot of emphasis on industrial requirements while devising the syllabus. And I'm really honored to be a part of today's seminar and as a presenter here. So I think I will start with my presentation now, and I will share my screen. So if there is some problem, please let me know if someone can't see this. Is it visible?
Yeah, visible.
Okay. So today I will be speaking on MRI in diagnosis of neuro disorders and its connection with everyday life. So this work was done during my PhD, which I did in IIT Delhi, and it also involved Fortis Hospital because the data that we got for this particular study was obtained from Fortis Hospital, Gurugram. So first of all, where does my research stand in the arena of biomedical engineering? Biomedical engineering as a discipline is quite an old discipline, but it was not known by the name of biomedical engineering till recently. So if we look into the stethoscope, which is something which doctors use every day, this is a biomedical product. And it has been there for the last 200 years, but it was not considered to be a part of biomedical engineering as such, but it falls under the category of biomedical engineering. So the broad areas of biomedical engineering that we know of today and that are taught in undergraduate courses in our country and abroad also are tissue engineering, biomechanics, and other branches mentioned here. So tissue engineering involves looking into cells and tissues outside the human body, that is in vitro, and looking into how those tissues grow outside. They can try to formulate how tumors grow outside the body. And then also they can use those cell culture and tissue culture techniques to develop vaccines, to develop antibodies. Antibodies is something of very much importance right now because of COVID-19, and likewise other applications are there. Biomechanics is another discipline of biomedical engineering which tries to develop prosthetic devices for people who are handicapped because of certain trauma or certain diseases, and they try to develop prosthetics for helping those people regain back normal life. My area of research falls into biomedical imaging, which tries to look into the different parts of the body non-invasively within the body itself. And most of the branches of biomedical engineering has a cross-disciplinary nature. So biomechanics, for example, has a lot of mechanical engineering involved in it. Similarly, biomedical imaging involves applications of signal processing, image processing, and artificial intelligence. Artificial intelligence is anyways one branch which is finding its importance in most of the other disciplines of science. So in my research, the core concepts of signal processing, image processing, and artificial intelligence will find a lot of application. Okay, so let's moving forward. Medical imaging. So interest in human body anatomy was there since long historic times. People always wanted to know what is inside the human body, and that was a normal human interest. But in ancient days, there was no option other than to cut the human body to look inside. And this could only be done when the patient had died or he needed a surgery. So there was obviously some requirement of some non-invasive way to look inside the human body. And with that came the advent of medical imaging happened. So it opened a new branch of medical imaging under which a number of techniques came. It started with X-rays when William Röntgen took the first photograph of the hand of his wife using X-rays back in 1895. A lot has happened after that in the last 115 years, or more than 125 years, actually. And a number of other branches of medical imaging has come in, like CT scan, PET scan, ultrasound, but none more important and none more clinically useful as MRI. And this is what I will be talking today for the rest of my lecture. So a little bit about MRI physics at first, a little bit, not too much. In our body, the protons consist of almost hydrogen atoms consist of around 70% of the human body, and the protons are normally in a random motion. But when there is an external magnetic field H0 applied to it, these protons align towards that magnetic field because all of them have a magnetic property. So the net magnetization M0 is in direction with the external magnetic field. And it has been shown that if RF pulse is applied to the main magnetic field in a perpendicular direction, the net magnetization vector M0 that flips towards the transverse plane from the vertical plane, it flips towards the transverse plane. And after this RF pulse is removed, then it again recovers back to its original state by emitting energy. And this emission of energy happens through two relaxation processes, T1 MRI and T2 MRI. So the rate of return of magnetization along the Z axis, that is the vertical axis, is called the spin lattice relaxation or T1 relaxation. And the decay of magnetization in the XY plane, which is the transverse plane, is called spin-spin relaxation or T2 relaxation. And these two are the founding pillars of MRI physics. Just a small trivia, T2 relaxation, T1 relaxation both happens simultaneously, but the rate of T2 is much faster than T1. Okay, so let's go into my research right now. conventional MRI and dynamic contrast enhanced MRI. So conventional MRI images are like T1 weighted, T2 weighted, and flared images that are shown here. And these are regularly taken in any clinical hospital. And these are the images of a brain tumor patient, of glioma brain tumor patient. And I think you can appreciate the hyperintense region in T2 weighted image and flared image. And these are the region where it encompasses the entire brain tumor. Although it doesn't give you a very concrete idea about where the tumor has occurred or is the origin of the tumor, it gives a broad idea of the tumor volume. But if you look into dynamic contrast enhanced MRI, it gives a concrete idea about what is the foci of the tumor. And this is where the advantage of T1 contrast enhanced dynamic MRI comes in. And this is the topic of research today. So dynamic contrast enhanced MRI involves injecting a contrast agent into the patient body, and that contrast agent travels through the blood into the tumor region. And then if there is a blood-brain barrier breakage, that contrast agent leaks into the surrounding region. And a number of images are taken simultaneously. That's why the term dynamic is used. And then a number of parameters are computed from that. So a number of parameters from DCE MRI are computed, such as using different models, such as first pass analysis, using tracer kinetic analysis, piecewise linear model analysis. These parameters give different information about the tumor biology. Suppose hemodynamic information of CBF and CBV, cerebral blood volume and cerebral blood flow, that we get from first pass analysis. Similarly, from tracer kinetic analysis, we get several physiological information which tells us about the permeability of the tumor tissue. And then there are other parameters that we obtain using piecewise linear model parameters. So all these parameters are very crucial parameters which gives a holistic idea about the tumor biology. And that's why dynamic contrast enhanced MRI has a very significant role in today's clinical world. Okay, so let's move into my research problem one, the first problem that I will be talking today. So it is regarding segmentation of glioma. So first, what is glioma? Glioma is a type of tumor that occurs in the brain. It consists of around 75% of all malignant brain tumors. The appearance of glioma tumor varies on different MR images. So the same glioma tumor appears differently on T1 contrast enhanced image and T2 weighted image. The appearance is different. Traditionally, the tumor was considered to have a contrast enhancing part, which is the hyperintense region in T1 contrast enhanced image, a necrotic part, which is this particular hypointense region or dark region in T1 contrast enhanced region, and a surrounding edema part. And this surrounding edema part can be obtained through the diffuse hyperintense region in T2 weighted image. So a different multiparametric approach is required to segment out the different parts of the tumor. Both T1 and T2 image are required. Around early 2010-2011, the RANO criteria came into being, and the RANO criteria suggested, this criteria was formed by radiologists all across the world, and they suggested that there is a non-enhancing component apart from the enhancing component which forms a part of the tumor. So this non-enhancing component is submerged within the edema part, and it remains diffused in the edema part. And the problem is the differentiation between non-enhancing component from edema is challenging because both appear hyperintense in T2 weighted image or flared image. So suppose in this T2 weighted image, you cannot differentiate the non-enhancing tumor from the edema. Like we can differentiate the contrast enhancing or the necrosis here. There is no such differentiation in T2 weighted image. So even using multiparametric approach, that is multimodality approach, T1, T2, and different other images, it becomes a different difficult problem to separate out the non-enhancing component from the edema. And why are we interested in segmenting out these different subparts? Because these different subparts have different functions. Suppose for the case of tumor surgery, a doctor would not be as much interested in segmenting out the edema as much he will be interested in segmenting or surgerying out the non-enhancing part. So for this reason, we need to particularly know what are the different tumor subparts before going for a surgery. There was another problem. So most studies which involve vasogenic edema differentiation from the non-enhancing tumor part, they take radiologist-based tumor delineation as the ground truth. And this was normally used in the early 2010 to 2015. But after that, there were research studies which found that the analysis by radiologists are found to be subjective. And there remains both inter as well as intra-rater difference. So within the radiologist also, there are some differences regarding the boundary of the tumor. So suppose in this case, you can see the same tumor has been segmented out differently, slightly differently by the 4 different radiologists. So there is a inter-rater difference in this case. And that's why the radiologist segmentation in case of vasogenic edema and non-enhancing tumor is not a very reliable process. So the goal of this study was to propose a methodology for differentiating between vasogenic edema and non-enhancing tumor in glioma patients, which is devoid of radiologist bias. So the solution that we came up for this is, so in cases of certain such differentiation, we normally use machine learning as a classifier. And machine learning could have been used to differentiate between non-enhancing tumor and edema. In machine learning processes, normally we have used SVM here, support vector machine. The general way that we arrange is we formulate a design matrix. And in the design matrix, there are class A and class B, which are denoted here as orange and green. And we can define the features in one of the sets and then the target vector or the labels in the other set. And then we can train the classifier on those particular features, and then on some new sample data, we can test the particular classifier. But the problem in our case is that we didn't know where did class A end and where did class B begin, because all the different features were mixed and we did not know the differentiation between non-enhancing and edema. And to make matters worse, we were not relying on the doctor's delineation for our study. So we had to come up with something else in this particular case. And that's when it came to our mind that we could use pre and post surgery images of glioma patients to obtain ground truth of the tumor boundary. So this is the pre-surgery image of a tumor patient, and this is after surgery. And initially it may look like a bit counterintuitive as to why we will be using post-surgery images. Let me explain you. So post-surgery, if after immediately taking this, doing the surgery, there are MRI images taken of the patient to look at how the tumor looks like after the surgery, if there is some part left behind or not. And it is expected that during the surgery, the doctor maximally takes out the maximum part of the tumor. So we can expect that the region which has been surgeried out encompasses most of the tumor part, that is both contrast enhancing and non-enhancing. And for contrast enhancing part, the segmentation is not that difficult. We can do it using standard algorithms like region-based algorithms using pre-surgery images only. So if we can combine both post-surgery and pre-surgery images and then segment and subtract out the contrast enhancing part, then what we will be left behind is the non-contrast enhancing part. And that is what we are looking for obtaining the ground truth of the non-enhancing part. So if we combine both pre and post-surgery images, then we can come up with a way of finding out the ground truth for non-enhancing part. And this was one part of our solution because we were still left out with segmenting out the vasogenic edema. So for that, what we proposed is we thought of using metastasis patients to obtain edema features. So metastasis patients are another kind of brain tumor patients. And for them, there is no non-enhancing tumor. There is directly contrast enhancing tumor and they have edema surrounding it. So the boundary between contrast enhancing and edema is very clear cut. And from them, if we segment out the edema part, that will be consisting of pure edema features. And we can use those edema features in our glioma patient segmentation as feature values for vasogenic edema. So using the first proposal, we can obtain a ground truth for non-enhancing tumor, and using the second proposal, we can obtain features for the vasogenic edema. And that was our solution and hypothesis behind the study. So directly showing you some of the results of the study, we used a support vector machine-based classifier for doing the classification. These are the images of 5 brain tumor patients, and the orange part are the regions which have been already segmented out using contrast, using region growing method for the, and this represents the contrast enhancing part. The differentiation that we did is based on the contrast non-enhancing part, which is this blue part, and these are the blue parts are the one which are correctly labeled classified non-enhancing tumor, and this particular sky blue part is the one which are misclassified contrast enhancing part. So as you can see, there are very few cases where there has been misclassification, and the error rate is very low in all the 5 patients. So this was a positive output of our particular algorithm. Then we tried to see whether this can be replicated in case of metastasis patients also. So we applied the same thing on metastasis patients, where we tried to segment out the vasogenic edema, and we correctly classified the vasogenic edema. The correctly vasogenic edema was represented by the brown or the maroon color here, and the yellow color represents the misclassified levels using our algorithm. And as you can see, there are very few misclassified levels, and the error for that misclassification is also very low. So for a new brain tumor patient, we could segment out the entire tumor boundary like this. And then we can, within that entire tumor boundary, we can segment out the different subparts of the tumor, such as the contrast enhancing region, the non-enhancing region, and the edema region, using our proposed algorithm. And for surgical purposes, knowing the contrast enhancing and non-enhancing region was very important for the surgeon. So we got very good results for this particular classification. The entire classification between non-enhancing tumor and edema had a misclassification of around 2.44%, which was clinically very much feasible and clinically useful for the doctors. So I prepared this presentation keeping in mind that everyone from every background of engineering or science can have some take-home message from this presentation, even though if their subject doesn't fall in MRI or image processing, they can have some take-home messages and they can benefit from this. And that's why I prepared certain slides for this. And that's why I have also put in the title, its connection with everyday life. So the first key take-home message from this particular part of the research was, we have to think outside the box if you don't find any solution inside. So in our case, when we were looking into the tumor, we were thinking of glioma tumor, and we could not find a solution for how to find out vasogenic edema, segment out it. And that's when we look into the literature outside glioma tumor, we found that there is another category of tumor called the metastasis tumor, in which the differentiation of edema and the contrast enhancing part is very clear cut. And that's why when we went outside our region of interest, that is glioma, only then we could come up with a solution. So the first key take-home message is, we have to think outside the box if you don't find a solution inside. Secondly, we have to break the chronology of approach if necessary. So the normal form of approaching a problem of segmentation is to work from front to back. Like we did the particular segmentation, and then we use those segmentation for surgical purposes. But we went one step ahead and we took the MRI results after the surgery, that is post-surgery results, and we combined it with pre-surgery results. And combining them, we ended up getting the ground truth for non-enhancing tumor. So sometimes we have to break the normal chronology of approach towards a problem and go beyond that to find a solution. And that's how we came out with the non-enhancing tumor part, boundary ground truth. So I hope this may benefit most of the people, at least if they don't get too much into the MRI part of the work. So moving forward, the next research problem that I will be discussing today is grading of glioma. So as I discussed, glioma forms a very dangerous type of brain tumor case, and it has a high mortality rate. So glioma is classified into grade 1, grade 2, grade 3, and grade 4. And the higher the grade, the higher the malignancy of the tumor and the higher fatal the tumor is. And this is according to the World Health Organization classification. According to American Brain Tumor Association reports in 2016, 55% of the glioma belongs to glioblastoma, which is a grade 4 glioma, and they have very high mortality rate. So there is a necessity to differentiate the different grades of glioma, so that based on that, doctors can devise their treatment policy. And this there is a huge clinical requirement for grading of glioma into its different grades. So that was one reason that motivated us to do this study. And the other thing is, the current gold standard for tumor grading is using biopsy. But biopsy has its own limitation. First of all, biopsy involves inserting a needle electrode into the particular person's brain. That itself is risky and has a lot of patient discomfort. Second of all, the tumor may be heterogeneous in nature, and needle electrode may pick out only a sample part, and sampling, there can be a sampling error. So if suppose the tumor is high grade, because of the needle electrode where it is inserted, it can take out a sample from the low grade region, because tumors are normally heterogeneous in nature, and that can lead to wrong diagnosis of the tumor grade. So there is a need of a non-invasive technique in glioma grading, and MRI fits into the bill accordingly very well. So the use of MRI could be that of a non-invasive technique that can look into the glioma grading device, define what is the glioma grade, and based on that, the doctors can come up with a solution of how to do the treatment for that particular tumor patient. So previously, literature exists in which MRI has been used for differentiating between high grade versus low grade of gliomas. High grade means grade 3 and grade 4, and a low grade is grade 1 and grade 2 combined. So there has been some literature that has looked into differentiating high grade versus low grade. But differentiation between intermediate grades, that is grade 2 versus 3 and grade 3 versus 4, has been not reported very much in literature, and there is a lot of clinical requirement for differentiating between the intermediate grades also, because based on that, the treatment therapy can be devised on based on that. And it has been found that the parameters from DCMRI, such as hemodynamic parameters, CPV, CPF, tracer kinetic parameters such as K-chance, VE, VP, etc., they fail to differentiate between the intermediate grades totally. So if you look into the parameters, suppose using CBF, you can see that there is a increasing trend of the parameter values as you go to higher grades, from grade 2 to grade 3 and from grade 3 to grade 4. But there is no clear-cut differentiation value or threshold value based on which we can get 100% classification between grade 2 versus grade 3. And this is true for all the other parameters if you look into them individually. So individually, all these parameters did not fare well for differentiation between the intermediate grades. Another set of parameters that people have looked into is morphological features, which involves the tumor shape and the tumor volume. And these parameters fare well in some cases, but they have low specificity in most of the other cases. So suppose, for instance, necrosis, which is the dead tumor tissue, they are mostly found in grade 4 tumors, and they are highly sensitive for grade 4 tumors such as glioblastoma. But they have also been found to be present in slight amounts in grade 3 and grade 2. So although they are highly sensitive for grade 4, they have low specificity for grade 4. Similarly, contrast enhancing tumor part, it is also mostly found in high grade tumors, but there are cases where contrast enhancing tumors can be found in low grades also. And thus these features cannot act as a biomarker because although they may have high sensitivity, but they don't end up having high specificity for those cases. So there was a requirement, and the goal of this particular study was to find an efficient way for differentiating between intermediate grades such that maximum classification between the intermediate grades can be obtained. So in this study, the first solution that we came up with is that combining two features is always better than a single feature. And we tried and tested it. And in this example, you can see that if the error using a particular feature CBV or edema, that how much we get is much higher than combining these two features. So the first idea was to combine as many features as possible, because combining two features always gives a complementary information, and that helps in getting better classification results using machine learning. So we ended up combining all the features, because combining all features may be a good idea to get better results for intermediate grade differentiation. We took features from each of these voxel. We took all the DCE parameter features like hemodynamic information features, contrast agent features, and other piecewise linear model features, all these features, and we formed a long feature vector combining all these particular features. We also included tumor volume features, because we have seen in literature that tumor volume also plays an important role, although they may have low specificity, but they have high sensitivity towards particular grades. So we formed a long feature vector. And then we had this for all the tumor slices. So we had a 3D stack, and we combined all the features from all the slices for classification purposes. So what we thought is that we would get good results combining those features, and that was true. Using combination of all features improved the results, and it was quite satisfactory for our purposes. But we thought that what if all the features may not be useful? That is, if some of the features are redundant. And that led us to actually look into it a bit more carefully. And we thought of sequentially adding the features one by one and looking whether all the features are actually useful for our purpose or not. And bingo, we got what we expected actually. We thought that there, after addition of certain features, the feature error may reduce, and that was true. And then after a certain point, it started to increase. So this orange line is the classification error, and these are the feature vectors. And these feature vectors are arranged according to their importance that we have got using random forest. And after a certain point, they end at the lower minimum value, after which they start increasing again. So we knew that we needed to stop here. And this was the sweet spot, as you can say, for our classification optimization algorithm. So feature optimization forms an important part in the process. So using these optimum features, these are the results you can see. The ROC curve, the black curve is the ROC curve using the optimized feature set, whereas these are the curves using other features which are having high accuracy individually. And the optimal feature set provides a higher ROC value and AUC value than any of these individual features. And this classification is for grade 2 versus grade 3. These are the results for grade 2 versus 3 versus 4. And we found that using different optimization algorithms, we can actually improve our results even more. So in our case, we can see that we have applied two different algorithms, the sequential backward selection method and the random forest-based method for feature optimization. And what we see is that using random forest, we get the minimum error of 9.43% for classifying between grade 2 versus 3 versus 4. And this involved around 54 patients combining grade 2 versus 3 versus 4. And this was pretty much a clinically feasible and viable result for the doctors to live with. So again, some key take-home messages from this part of the research work. The firstly is 2 hands are always better than 1. So when we were working with individual features, we were not getting very much good results. But when we combined the features, we got better results than using a single feature. And that's why the multi-parametric approach has always been right now the used thing in most of the studies. Another observation was too many quick cooks spoil the broth. So using all the features may actually not give you the optimal results, because we saw that when we combine all the features after a certain point, the error actually started to increase. So we need to know where to stop. And that's why the entire process depends on optimizing your feature set. So the key message is optimization of your resources is the key towards getting good results for your study. This brings me to the third part or third research area that I'll be talking today. And this has to do with a little bit of MRI physics. So there is something called B1 inhomogeneity, and the effect of B1 inhomogeneity is evident on computation of the different perfusion parameters, which actually leads into affecting the grading of the tumor. So first let us see what is B1 inhomogeneity. B1 field is the magnetic field which is applied by the RF coils in a direction perpendicular to the B0 field. B0 field is this one, which is in the magnetic field direction, main magnetic field, and B1 is the perpendicular field to it. And this B1 field is required to flip the net magnetization vector from the vertical direction towards the transverse plane. And it needs to be applied at the Larmor frequency. So the Larmor frequency is the frequency in which the protons wobble. When the external magnetic field is applied, the protons wobble at a particular frequency. This is known as Larmor frequency. And the Larmor frequency of protons is proportional to the B0 magnetic field, that is the outside magnetic field. Thus, the RF coils needs to generate a high frequency pulse at 3 Tesla compared to 1.5 Tesla, because it is proportional to the outside magnetic field. And what happens if you go to high Tesla is, at high magnetic fields like 3 Tesla and above, the RF wavelength is shorter than the dimension of the anatomical structure. So as you can see that as we go to higher magnetic fields, the dimensions, the wavelength reduces, and it's at a certain point, it actually becomes lower than, shorter than the anatomical structure of study, which is brain in this case. And this is a property of RF waves, that at high magnetic fields, they have shorter wavelength. And which results in actually the RF power being absorbed differently across the region of interest, which was brain in this case. And the RF, since it gets absorbed differently, it results into something called B1 inhomogeneity. This is a B1 inhomogeneity map from the brain region. And you can appreciate the fact that the values are higher in the center part and the values are lower in the periphery. And the values approximately range from 0.8 to 1.2, with 1 being the nominal value, that is the value if there was no inhomogeneity, this value of 1 would exist here. But this 1 value is something which is an ideal situation. In reality, the values vary between 0.9 to 1.5, 1.15, and it can also vary somewhat to 0.8 to 1.2 in certain cases. So just to give you a broad picture, I have given this particular image. So how does it actually affect grading and computation of different perfusion parameters? Let's look into a bit more into it. So I don't want to frighten you with this particular image. This is a very complex figure, but I will try to break it down into subparts to explain it. So on the right, in the red colored box, is the part which involves computation of the different dynamic contrast enhanced parameters that we talked about initially. So this is the prerequisite, the T1 map data and the DCE MRI post contrast and pre contrast image. These are the prerequisite for the computation of contrast of the parameters. And these are the final parameters that we obtain from this process through a complex process that happens in between that I'm not going to discuss right now. And B1 inhomogeneity is on the left, and it affects the computation of parameters at two different levels. It affects both the T1 map data as well as the DCE MRI pre and post contrast data. So for T1 map data, the signal intensity of the T1 map data is obtained through this particular equation using a particular sin theta factor, and this theta is originally, if there is no B1 inhomogeneity, then theta remains as it is. But if there is some B1 inhomogeneity, then theta is deviated from its nominal value. And that's why if this particular theta is deviated from its nominal value, the calculation of signal S changes, and this particular error is incorporated in T1 map data, which percolates into the other parts of the computation process of parameters. Another stage where B1 inhomogeneity affects is in the computation, or in the computation of the DCE post and pre-contrast images, and this involves this particular complex equation, and this equation also has this particular parameter theta, and if there is a change in the B1 inhomogeneity, this theta is deviated from its nominal value, and these values are changed, because of which their final computation may be changed. So in literature, we found that there has been work which has looked into this particular parameter theta and how T1 map data can be corrected into it, but they haven't looked much into the DCE MRI part of it, and especially for brain data, we didn't find any literature. At least when we did this study, there was no such literature. So we were quite interested as to how, if we correct this theta after B1 inhomogeneity, then we would lead to actually computation of corrected parameter values, and that will help us in doing grading study much more efficiently. But unfortunately, when we talked with the doctors, we were not able to invoke much interest in them regarding this purpose, and we didn't know much why it is so. But later on in the study, we got to know why is that, and that I will come a bit later into the talk. So the goal of this study was to evaluate B1 inhomogeneity on quantitative analysis of DCMRI data of human tumor patients, brain tumor patients, and to evaluate the clinical significance of B1 inhomogeneity correction. So this is one example which I will show, and here is a tumor patient, and there is one particular ROI here, and we are looking into this particular ROI. You can see that that particular ROI has a high B1 value here, and its value is actually 1.15, which is around 15% higher than the nominal value. And because of this, if we do the correction of the perfusion parameters, we see that there is a relatively high value of changes for different parameters, and some of the parameters like V gets changed by approximately 15%. So we were convinced that because of correction, there is a lot of change in the perfusion parameters. We wanted to see whether it affects the grading or not also. That I will come in the next slide. So we devised a grading study for this. We had a cohort of around 35 patients, out of which 12 were low grade and 23 were high grade. And we did compute the perfusion parameters both before and after B1 correction. And after B1 correction, what we found is that the variation of parameter values within the same grade reduced a lot after B1 correction. And for some cases, it reduced by 15%, such as in case of VP. So reduction of variation means the parameters value within a certain grade becomes much more homogeneous. And that means differentiation between different grades becomes much more easier. The difference between two grades becomes maximized because within a grade, the values are becoming much more homogeneous. So this was our pre-assumption behind it. And then we looked into how the actual ROC analysis and results changed because of it. But the ROC analysis results were not very much encouraging. So these are the ROC analysis results, the sensitivity, specificity, AUC before correction, and these are after correction. So if you look into the AUC or the area under curve, you can see that the values for these particular parameters do not change much from before correction to after correction. For example, K-trans has around 0.859 AUC before correction, and after correction it is 0.866. So it is hardly any particular change of which may be of clinical significance. And that's when we got to understand that maybe because of this, the doctors may not be actually interested in doing this particular study because it did not have much clinical relevance. But we deep inside, we knew that there was a technical error in the computation of the parameters, and we wanted to dig inside to see why this error is not actually showing up during the grading of the studies. So we thought of doing some more simulation studies to understand this process. And so we went into doing some simulation studies. So we used K-trans as our parameter here, and we took 10 random subjects for our study. And we changed the B1 value from 0.75 to 1.25. That is, we simulated different B1 values and we computed K-trans values for each of these particular B1 values. And we looked into 10 such patients randomly. For this particular experiment, this cutoff value of a threshold value was 0.077, which is in the dotted black line, if you can see here. And we saw that out of the 10 patients, actually 4 patients had their K-trans value change from one grade to another due to this simulation study. And if we look into those 4 patients a bit more deeply, we can look into them by zooming into those 4 patients specifically. So suppose we talk about this particular patient, which is in the blue line, the nominal value of it at B1 is equal to 1 is around 0.085. And if you increase the B1 value higher than 1, then it remains in the same grade. So in this case, it is above this particular cutoff line, that is, it is a high grade case, and it remains high grade if you even increase it till 1.25. If you lower the B1 value to 0.075 at the fag end, it changes the grade. And that is some 0.075 is something that we normally don't see in case of practical cases. In practical cases, it ranges between 0.09 to 1.15 or 1.2. And similarly, you can see the same thing happens for this particular patient in brown, which changes its grade only at the fag end. For the other 2 cases, there is a change of grade within the particular range that is feasible or plausible in case of MRI studies, that is between 0.09 to around 1.2. And this is because their values at the nominal value is close to the cutoff value of 0.077. So if the values are far away from the cutoff value, then it may not actually change even if you apply a high B1 inhomogeneity at that particular ROI. So the conclusions from this were appropriate cases for illustrating the clinical significance of B1 inhomogeneity effect are those where the perfusion parameters at the ROI have values near the near cutoff grading, that is, it has close values that near the cutoff value, and its location coincides with a region of high B1 inhomogeneity. And these 2 particular cases has to satisfy. And this may not happen in majority of glioma patients, and it can purely depend on chance. And that's why in real practical cases, we may not have too many cases which significance of B1 inhomogeneity. But in theory, there is a high importance of doing this study to show that if we have taken a number of patients, this would have definitely mattered in grading. So again, key take-home message from this particular study, and this is the last study, is firstly, appearances are often deceiving. So in our case, we thought that since the grading was not affected, the parameter values may not get changed because of B1 inhomogeneity. But we were wrong. The parameter values were actually getting affected because of B1 inhomogeneity, but still the grading was not getting affected because of the other simulation studies told us that it has to happen 2 simultaneously situations has to satisfy, and only then the grading will change. And that's why we were not actually having any thought of doing that study initially, and the doctors were also not very much interested. But technically we found that this had a lot of significance. So appearances are often deceiving. Secondly, when in doubt, try to do simulations. In reality, we could not have tried to get so many different B1 values from 0.075 to 1.25, even if we had worked with maybe 100 or 200 patients. But using simulation, we could do that study, and we could find out why the change in parameter, change in B1 did not affect the grading using simulations very easily. And that's why, if possible, always we should try to do some simulations to better know about the subject. So with this, I will end my presentation today. I would like to acknowledge IIT Delhi and Fortis, where this work was done. And I would like to acknowledge my group members, my mentors, Dr. Anup Singh, Dr. Sumit Agarwal, and Dr. Rakesh Kumar Gupta, who were my mentors and guides during this process. And thank you for listening to this talk. I'm happy to take any questions from your side. If you have any, please let me know. And if you have some other questions also, which you are not able to ask, you can always reach me at my email ID. So should I stop? Okay.
Yes, Dr. Anirban, yes, you give a splendid information and a splendid presentation in front of us. But I'm really amazed at how you did this all study, because there are a lot of difficulties in when you maybe you face, especially when you talk about the there's a it is very hard or very difficult to separate the edema part with the non-enhancing tumor. And even the radiologists have, I mean, they also differ in the demarcating these all lines. So may you please share your experience, how you get the data from the hospitals, because in India, the patients are also reluctant to spend a lot of money on the imaging part, because yes, on the treatment they are agree, but on the imaging side, the data is not ready with us. Second thing is again how we get the label data, the correct label data to train the SPM.
Yeah. So thank you, Mr. Sandeep, for firstly hosting me and then asking these interesting questions. So one quick question: should I stop share or should I keep it like this?
Stop sharing, sir. You can stop sharing and we can.
Yes, sir.
Okay. So. So the first thing is that how do we get this data? So our work in IIT Delhi had collaboration with Fortis Hospital, and Dr. R.K. Gupta, who is the head of the radiology department in Fortis Gurugram, was in charge. And I was really lucky to work with him, because in not many hospitals all over India will get such a rich resource of data and database of patient data. And he was someone, he always used to be interested as much in his clinical work as much he was interested in his research. And although this work was in one way, actually, one of the studies were actually talking about the negative part of incorporating radiologist delineated data, he was not at all hesitant in accepting that. And he himself actually motivated me, because he said that there are some faults within doctors also in this delineation of tumor, and we should come up with a much more less biased way of approaching the problem. And since there was a need as per literature, we came up with this solution, and it was accepted in one of the journals. So I got high motivation from the doctors involved in this study, and that was a plus point in this particular research. And I accept that many hospitals in India do not have this much of service available to get this data, and that's a major limitation for this type of studies.
Yes. So, so one more question, if you have a time, sir. So one of our audience want to know that what type of simulation platform we you use for this study, whether it is I mean ready-made tools or you develop it from the scratch.
So we used MATLAB-based tools, and all the codes were written in MATLAB, and it was developed by us. It was not developed by any particular software. We used a MATLAB platform. The only thing that we required is to know about the equations and how they relate to each other. And after that, we could develop the codes on our own. And I would suggest to, if someone is trying to develop something, it is better to do it on their own, because that gives you a much more flexibility. If it is available, then it's fine. But if you want to do much more tweaking with the parameters, then you should develop the code yourself.
There's a question from one of the students who has messaged me. The question is about the radiations of this MRI scanning and all. Are they dangerous for any
No,
part of your body?
no. The radiation from MRI is not dangerous. MRI, in fact, doesn't have radiation. It is from CT scans and X-rays that we get radiation. MRI is a non-ionizing thing, and still now it has not been proved to be having any effect on our body. Yeah, there are some cases where people have worked on the effect of contrast agent injection on the human body, and dynamic contrast enhanced MRI involves injecting a contrast agent. But those results are also found to be, those fear is also found to be unfound. Like people have done a lot of research on it, and after even 20 years of it, people have not found any significant evidence of having any fatal effect of doing DCE MRI, contrast agent injection.
There's another interesting question. They are asking me, like, asking you, in fact, the speaker, that what are the limitations of these, these scans which you mentioned?
So the limitation of the particular study is that, first of all, in any case of clinical study, you need to have more number of samples. And if we can do this particular study maybe on another 100 number of patients, then the results may change a bit. But we strongly believe that this number of samples was sufficient enough, because we did some sample size calculation before the study. But in general, the higher the number of samples, the better it is. And another limitation which I would like to think of is that it's often possible that when we get the data, the protocols are not fixed a priori. So most of these studies are retrospective studies. That is, we didn't develop the protocol for this study. This type of protocol was already existing in a particular clinic, and we use their data. And what happens is that since it has already been developed there, the protocols are not devised according to our requirements. And so we have to fit in our goals according to the already existing protocol in that particular hospital. So that is one limitation that we have to live with. The more important and difficult thing is that if those protocols change over time, then our experiments has also to manage with it. So since in India, we don't have many places where there are research-oriented scanners, and that is something which I see when I come outside, and I'm right now at the US. So I can see that in most educational institutes, they have their own research scanners. So they can actually do all the protocol setting on their own, and they can devise their research project as they want. But in India, unfortunately, it is still not the case. And that's why we have to adjust according to the clinical requirements at that place. So that is one limitation.
There's a question from Viswajit today. He's asking, does the value in the samples vary with the geography?
The value of the samples?
Vary with the geography.
Geography, yeah. The demography plays an important role in these studies, and we always, in our reported researches, we always report from which locality has this study been, data has been obtained, what is the age, what are the gender, what is the mean age, plus minus SD. All of these things have a role, and we generally report all of this. And since in our case, the entire study was in India, we didn't have to worry much. But if you are talking about a multi-centric approach, then you have to take, where you are taking data from multiple centers, then you have to take into account the demography of the different places.
Sir, I have a question from my end, actually. When you are going through all this research, can you just remember any incidences where you said, or you thought, okay, oh, this is a very beautiful result which I'm getting, and any incidents where you thought, array, what is this result? I'm not at all, be able to correlate with what I've studied or what I'm seeing outside. Some small of such incidences if you have.
Yeah, I remember particularly one particular case where, so I had in one of the slides, I remember I showed you one case where I had to put a ROI in a small tumor place, and I had to show this in that particular ROI, the B1 inhomogeneity is high, and there is a lot of change in the perfusion parameters. And I was stuck on this problem for a long time, because I was working I worked on a multiple number of patients, and I was not able to found on a suitable case or an optimal case where I could showcase my hypothesis that I was trying to depict. And my guide, my professor was very persistent in this, and he motivated me that you should give as much time as possible, because these representative cases are very much important when you publish it in a paper. As I told at the end of my research work, that in many of the cases, this may not have any clinical significance, but there are certain cases, and case studies are the pillar of any clinical study. There will be a particular case study which actually opens a new field only. So I had to do that find that particular case in which this particular hypothesis that we were looking for was true. And that took me a long time. And finally, when I found that particular place, I still use that particular image in any presentation that I use, because that was a classic example. And yeah, so that incident I remember.
What is your suggestion or advice for the people who would like to take biomedical engineering as their career, and especially in the post-COVID region?
So post-COVID, the importance of biomedical has increased even more. I have been in biomedical for the last 16 to 17 years since my undergraduate days, and I have seen this biomedical thing grow in India basically, apart from few places where it already existed by that time, but most of the other places didn't exist back in 2000, early 2000, middle 2000. And now it is there in many places, and I am very optimistic that it will have a lot of other new colleges also coming up with this. After coming outside India, I found that biomedical engineering is the hottest discipline out there, because most of the people who are having the highest marks and highest grades, they go for biomedical engineering. Here the most scope for research is there in biomedical engineering, as well as most fund from the government is also there for biomedical engineering. And I hope that this thing comes true in our country also, because biomedical engineering is one discipline which is going to change the human lives. And that is at which we can right now appreciate after the COVID-19, that the maximum research funding should go towards those sectors which works on human life development. And biomedical engineering is one such discipline.
I think there are no more questions in this. Jogi sir, would you like to thank her? Or shall I?
Yes. So Dr. Anirban, really we are thanks for you from bottom of our heart that you give the splendid presentation, especially you incorporate the all things like from the basic, from what is MRI and then you go for the research area, and then what are the problems and what are the take-home messages. This really enlightened us how to present and how to do the research activity continuously. So we are grateful for your presentation. Thank you, sir. Thank you.
I am also very much thankful to you people for inviting me to present here, and I purely from the bottom of my heart, I also thank you. And it is my privilege to actually give a talk in esteemed universities such as MIT University. Surely.
Dr. Anirban, so nice of you. Thank you so much for connecting with us. We hope to continue with some more programs of this type. Thank you very much. Thank you.
Yes, sir. Sure.
Thank you, sir.
Okay.